Okay, let me just make you co-host. Okay, I think you're co-hosting now, so I hope you'll be able to share.
Not yet, sir.
The name is Dr.
Vipin.
What's your username appearing as?
Dr. Vipin Goel.
Ah, okay, sorry.
Yeah.
Sorry about that. You should be able now to
Yeah.
co-host. Yeah.
Arthur, can we start the session?
Yes, please. We're happy for you to start.
You can give that small welcome and then I will introduce the speaker.
All right. Thanks everyone for making it again today in this regional anesthesia lecture series, which we hold every other week on a Friday from 6 p.m. Central African time for about an hour usually. We've had this series for about 2 months and we hope to go on for at least another 2 months. So we'll be happy to continue hosting this arrangement for the foreseeable future, and we're happy if everyone could continue joining us. So today we have lumbar plexus blocks, which is presented by our colleagues from Ganga Hospital in India. We were very fortunate with a new relationship that we've developed over the past few months with our colleagues at Ganga. And I'll let our presenter for today give an introduction of his background and today's discussion. Please go ahead.
Thank you, Dr. Arthur. It's been a pleasure to be a part of a program jointly organized by the Global Anesthesia Development Partnership, the Zambian Society of Anesthesiology, and the Department of Anesthesia at Ganga Medical Center and Hospital, Coimbatore. It's a pleasure and privilege to share one of the most important components of the modern anesthetic practice is to do a regional anesthesia and analgesia, which seems to be of phenomenal help in decreasing the postoperative pain, decreasing the intraoperative requirements of anesthetic agent when it is combined with general anesthetic, and also seems to be decrease the amount of blood loss during the surgical procedure. Yeah. But what we have visualized is the best part comes post-procedure, and the amount of comfort the patient gets after major tissue injury seems to be less. And also whenever you're not able to give a neuraxial block, then it becomes important in critically ill patients whom neuraxial block cannot be given will hugely benefit from the lumbar and the sacral plexus block. So today we are going to deal with the sacral plexus block. To present this, we have with us our consultant anesthesiologist, in Department of Anesthesia, Dr. Vipin Kumar Goel, who is part of the organization and our department. He joined us as a fellow in regional anesthesia. After completing his 1-year tenure, he continued with us and almost has got a decade-long expertise in regional anesthesia. To his credit, he has got several publications, chapters, and also he has been a part of the workshop faculty at the national conferences and also in the recently held World Congress of Anesthesia in Prague virtually. And may I take the pleasure in introducing Dr. Vipin Kumar Goel to take you through the journey and make the complex sacral plexus block pretty easy, which would hugely benefit your patients. Over to Dr. Vipin Kumar Goel.
Thank you, sir. Thank you, sir, for the introduction.
Recording in progress.
Good evening to all. Greeting from India and from the Department of Anesthesia and Perioperative Care, Ganga Medical Center and Hospital, Coimbatore, Tamil Nadu. It's my privilege to be a part of the Regional Anesthesia webinar series going on, and I welcome all my overseas colleagues from Zambia Regional Anesthesia Society and from India for this interactive session today. I am Dr. Vipin Kumar Goel, Consultant, Department of Anesthesia, Ganga Hospital, Coimbatore. So, declaration, I have no conflict of interest. All illustrations used in my presentations are adapted from elsewhere. Complete Anatomy app 8.0 and appropriate patient consent has been taken. So, it is important to have a good anatomy understanding while performing any block, especially deeper blocks, as it gives boost to your confidence to perform that block, especially deeper blocks, and it will supplement your skill to appropriately readjust the needles while performing the block. And it will help in avoiding needle-related injuries, and you can adjust the needles, and it will timely recognize the unusual complications. So let's start with the anatomy. So as you know, sacral plexus, it is formed by the first 3 sacral nerves and get branches from the 4th and 5th lumbar nerves. It also gets branches from the 4th sacral nerve. Basically, it is located on the posterior pelvic wall, covered by the pelvic fascia, and it lies anterior to the piriformis muscle. And it is in there. Sacral plexus is in close relation with the internal iliac vessel, ureter, and colon and rectum anteriorly. So, as the plexus enters the posterior part of the thigh through greater sciatic foramen, it lies inferior to the piriformis and deep and lateral to the inferior gluteal vessels and nerves. As it goes further caudal, the plexus lies over the gamillae, superior inferior gamillae, quadratus femoris, and obturator internus. So, it is important that if you have any if any person is performing the block, to study this cross-sectional views as frequently as possible to assess the anatomy. Like in this view, you can see the sacral plexus is coming out of the nerve roots of the vertebral body. Then it is going through the greater sciatic notch and into the posterior part of the thigh. These are our bony landmarks, sacrum and ilium. And as the sacral plexus passes into the posterior part of the thigh, it lies under the piriformis and the gluteus maximus muscles. You can also see that it is in close relation with the internal iliac vessels, rectum, colon. So if you go further down caudally, so another section, cross section, where you will see that plexus has come out of the greater sciatic foramen, and it is lying into the posteriorly medial part of the piriformis and gluteus maximus. And there it is coming along with the inferior gluteal vessels and nerves. So this is the plexus coming out of the greater sciatic foramen. Now in the coronal section, if you see after skin and subcutaneous tissue, When you go, first structure you will interact is the gluteus maximus muscles. When we pierce through the gluteus maximus, the next muscle we interact is the piriformis muscle. So under the gluteus maximus, the second muscle which we come across is the piriformis muscles. And you can see that superior gluteal vessels above the piriformis and inferior gluteal vessels and nerves are inferior to the piriformis muscles. After piriformis, when you retract or you go through the piriformis, the next structure you see is the sacral plexus that is coming out of the greater sciatic foramen and going caudally down over the superior inferior gamellae and the quadratus femoris along with the inferior gluteal vessels and nerves. So what are the branches of the sacral plexus? The main branch of the sacral plexus is the sciatic nerve, which consists of tibial nerve and that supply the most of the hamstrings, calf and sole. The other branch, common fibular nerve, which supplies the muscles of the anterior and lateral compartment of the leg and the skin over it. Other branches of the sacral plexus supplies basically the pelvic girdle and the perineum. So, what are the other branches? Now to quadratus femoris, now to operator internus, pudendal nerve, superior gluteal nerve, inferior gluteal nerve, now to piriformis, posterior and perforating cutaneous branches, and the pelvic splanchnic nerves. So it is important to know all these branches and to know whether, when, and where to use this parasacral block. We should be thorough with the lower limb neuroanatomy. And what are the other blocks, which are all the other blocks we have to supplement with this, we'll get to know by knowing the neuroanatomy of the lower limb. For that, we will study the dermatome, myotome, and osteotome of the lower limb. So first, we'll see the dermatome. If you see the dermatome, the anterior part of the thigh mostly is covered by the femoral nerve, except the medial most part, which is covered by the obturator nerve, and the lateral most part, which is covered by the lateral femoral cutaneous nerve. And below the knee joint, if you see, the most of the medial part is covered by the saphenous nerve, and the lateral part is covered by the common peroneal nerve. Similarly, if you see the osteotome, the anterior part of the femur is mainly supplied by the femoral nerve, except medial most part, which is supplied by the obturator nerve. And below the knee joint, and the posterior part of the femur is basically supplied by the sciatic nerve, and lateral part by the femoral nerve, and medial part by the obturator nerve. And below the knee joint, if you see, the most of the bone is supplied by the branches of sciatic nerves, like common peroneal nerve and sural nerve and tibial nerve. Now the myotome. If you see the myotome supply, the muscles which are supplied, the anterior part of the thigh, most of the muscles of the anterior part of the thigh is supplied by the femoral nerve, except on the adductor part of the medialmost part of the thigh, which is a hip adductors, this is supplied by the obturator nerve. And below the knee, all the muscles are supplied by the tibial nerve and the common peroneal nerve. So on the basis of dermatome, myotome, and osteotome, we can decide in which surgeries these block is required, and along with this, which other block we have to supplement with this. So according to this, we will see what are the indications on the basis of dermatome, myotome, osteotome, like hip surgeries. If you supplement it with lumbar plexus block, we can do the hip surgery under this. Even awake hip surgeries we can do with this. Other surgeries are around and below the knee joint using a thigh tourniquet. And it can be used as in post-operative pain management after thigh or leg amputation, like posterior popliteal fossa surgeries or total knee arthroplasty. Contraindications are usually like infection, coagulation disorders, any neurological deficit, or sacral decubitus ulcers, or inability to assume the lateral decubitus position. These are the common contraindications. So, what are the different types of sciatic nerve block techniques? So sciatic nerve can be blocked at the level of parasacral, at the level of gluteal, subgluteal, popliteal, or anteriorly we can block the sciatic nerve, or lateral approach. So in this particular seminar, we are going to discuss about the parasacral and gluteal approach of sciatic nerve block. In the parasacral approach, we are going to block sacral plexus, while in gluteal, we can block both sacral plexus and mostly sciatic nerve. So in parasacral, the PNS technique we used is Mansour's approach, while ultrasound guided, we used mainly Taha's and Benston's parasacral parallel shift approach. While through gluteal approach, through PNS, we are using classic Labart's or Vinnie's modifications. So if you see in this image, this is the different site of different approaches and their injection site. Like if you see that number 1, this is we give injection when we perform the sacral root block, nerve root block for analgesia. And this is 2, that is under the piriformis. This is the site where we usually give injection while doing parasacral sacral plexus block. And this is the 3rd point where we are using Labart's technique. Through Labart's technique, this is the site of injection we are giving the block. So at this point, and the 4th is the Vinnie's modification. So these are the points where we are blocking sacral plexus and sciatic nerve. While 5 is the point where the GTIT line of by Raj techniques we are using block injection, and 6 is the point where giving injection during subgluteal approach. So in this lecture, we are more concentrating on the 2nd, 3rd, and 4th, that is parasacral, Labart's technique, and Vinnie's modification. So before going to blocks, we will see what are the bony landmarks which we will come across while performing the blocks by either using PNS or either using ultrasound guided. So this is a picture of a hip bone with sacrum. And if you see in this hip bone particularly, this is the ilium of the hip bone. Then this is the posterior superior iliac spine. This is the ischium. This is the ischial tuberosity. And this is the posterior border of the ischium. And this particular part is the greater sciatic foramen through which the sacral plexus and the sciatic nerve comes out and goes posteriorly into the thigh. And where we are targeting our injection during parasacral approach. So in parasacral approach, first PNS. In PNS, we are using most common and most older is the Mansour's parasacral approach. What we do in this patient position is the lateral decubitus position with the blocking limb will be above and the other limb is lower, which will be either you can keep straight or flexion at the knee joint. The main landmarks are the posterior superior iliac spine and the ischial tuberosity. And we'll join these 2 points, and the 6 centimeter caudal to the posterior superior iliac spine is our needle insertion point. At this point, our needle will go perpendicular to the skin, parallel to the floor, and perpendicular in all planes from posterior to anterior direction. If you see, so when we go from posterior to anterior, our target is this greater sciatic notch or foramen, which is 6 centimeters lower to the posterior superior iliac spine. So what happened when we give this parasacral block, the needle passes through the greater sciatic foramen and deposits the drug deep within a facial plane between the piriformis and the pelvic fascia. So by this, we block both components of sciatic nerve, that is tibial nerve and the common peroneal nerve. Along with that, posterior cutaneous nerve of thigh will also get blocked. And because of spread of local anesthesia in the facial plane, it will block the superior inferior gluteal nerve, pudendal nerve, splanchnic terminal branches of sympathetic trunk, and inferior hypogastric plexus. So while performing this block, what are the response expected? When you give the using the PNS, either you will get inversion of foot, plantar flexion of the foot, hamstring contraction, or the dorsiflexion or eversion. This is the unique in parasacral block that any of these responses accepted, because at this parasacral level, all the nerve roots, even tibial, common peroneal, and the nerve to hamstring muscle, they are in very close proximity, even together. So whatever response you will get, that is accepted in this particular block. So either most common is the hamstring muscle contraction, and any when you received, that will be accepted. So next is the Labar's approach and Vinnie's modification. So in this, what are the landmarks? Same posterior superior iliac spine, greater trochanter, sacral hiatus. And this will put a midpoint of that line from the posterior superior to greater trochanter, put a perpendicular over this line, and 4 to 5 centimeter on this line is our point of insertion, needle insertion point. So let's see live video of how we assess and do the block in using parasacral approach or a gluteal approach also. So in this, patient is in the decubitus, lateral decubitus position. The blocking side limb will be above and the non-blocking side limb is below, and that you can keep straight or flexion at knee joint. The blocking limb will be with the flexion at the knee joint. Then we'll palpate the anterior superior iliac spine and the iliac crest. Then you go posteriorly and caudal. As you go posterior and caudal, the most prominent bony part you will feel is the posterior superior iliac spine. The other way of identifying is that you will see the dimples. You can see here 2 dimples. This is most of the time it is, you can easily identify those two. Even in obese patients, these dimples are prominent. So this is dimple denotes, corresponds to the posterior superior iliac spine. Then go to the lateral most part of the thigh and lateral and superior most part of the thigh. And that bony prominence you will feel is the greater trochanter. So when you join these 2 points from the posterior superior iliac spine to the greater trochanter, then take a midpoint of this line and put a perpendicular over this line. And that 4 to 5 centimeter on this line is our needle insertion point. Here the needle will go perpendicular to the skin, parallel to the floor, and from posterior to anterior. Then the Vinnie's modification. What is there in Vinnie's modification? We will get one more landmark, that is sacral hiatus. And then you put a line from the greater trochanter to the sacral hiatus. And where this line is cutting, that perpendicular line is our insertion point in Vinnie's modification. So this is a video by giving block by Mansoor's approach. You can see we are going perpendicularly and parallel to the floor, perpendicular to the skin. You will feel the gluteal contraction, and then you go further deep and you will see the hamstring contraction that is accepted. Going in. You can see that this is hamstring contraction, and then you will also get foot contraction, either dorsiflexion or plantar flexion. So any of these response is accepted. So in this, we are getting the dorsiflexion. Then you reduce the current up to 0.3 you will go. And if it is coming 0.3, then withdraw the needle a little bit, and up to 0.4 it is accepted. At 0.4, if you are getting, then you inject the drug, and as soon as you give 1 or 2 ml, the response will disappear. The response should not come less than 0.3. That means you are interneedle. So you have to withdraw the needle up to 0.4. So what are the problems and what are the points you have to keep in mind while performing the block, either using PNS or ultrasound? If you are using only PNS, then you have to select a fastest twitch rate in your machine, PNS machine, that is 5 Hertz, and current of 1.2 milliampere, because you have to stimulate it faster. But if you are using ultrasound with PNS or dual guided method, PNS is just to verify the needle. So you can come down the twitch rate up to 1 Hertz, and you can keep the current also 0.5 to 0.6 milliampere. So next is, if you are getting bony contact while giving this, and you didn't get any contraction, any muscle contraction, then you have to reassess your landmarks. Maybe you are too lateral, or you are maybe too medial or cephalate. So how you will see, amplify what you have to do next step. See, if your needle looks medially directed, that means you are hitting the sacrum. So you have to redirect your needle laterally. So if you can see, I can show you in this image. If you put it in the lateral position, So if you are going perpendicularly like this, and you're hitting the bone, and if your needle looks like medially, that means you are hitting the sacral part. So you have to come and direct, because our target is this greater sciatic notch. So you have to go little laterally. And if your needle looks laterally and you are hitting again bone without any, that means you are hitting the ischium part of or ilium part of the hip bone. That means you have to withdraw and you have to redirect your needle medially. Similarly, if your PS, IS and IT marks are correct and your needle is exactly perpendicular, not medially or laterally directed, and still you are getting the bone, that means you are hitting the ilium part of the bone, or you are kyphelate. So you have to withdraw and you have to redirect into the caudal direction into the greater sciatic notch. So that is first point, if you're getting bony contact without contraction. If you're not getting bony contact, but you are getting contraction, but still you are not getting appropriate contraction, like if you're getting tensor fascial lata contraction or gluteus medius or minimus contraction, what does it implies? It means your needle is kyphelate and lateral. That is, you are stimulating the superior gluteal nerve, which lies kyphelate and lateral to the sacral plexus. Then you have to redirect the needle caudal and medially. Similarly, if you're getting gluteus maximus muscle contraction, that means you are stimulating the inferior gluteal nerve, which lies caudal and medial to the sacral plexus. That means either you have to go little deep and directed the needle laterally, deep and lateral, because inferior gluteal nerve is superficial to the sacral plexus and it is like caudal and medially. But if the patient complains of genital tingling, that means you are getting pudendal nerve stimulation. So you have to reposition your needle and you have to do it laterally and superficial. You have to come superficial and you have to redirect your needle laterally. So, and always avoid needle advancement 2 centimeter after any bony contact, like sacrum, because chances of getting pelvic organ injury is high. And if you place your needle deep enough, like around 10 centimeter, and you didn't get any twitch, that means you have passed through the sciatic notch or you are too inferior. Then withdraw and redirect the needle slightly lateral and kyphelate. What are the most complications? The most common complication you will see is the urinary retention. That is because of pelvic, splanchnic, and distal sympathetic block. Other complications are very rare, like if you can see hypotension, if the sympathetic block happened, like if you have used too much of volume and that spreads proximally causing sympathetic block. And the remote risk, very remote risk, is the subarachnoid space injection or needle puncturing the colon or rectum or bladder if you have gone through the greater sciatic notch into the pelvis. So this is the PNS-guided sacral plexus block. Next, we will go to see the ultrasound-guided sacral plexus block. So in ultrasound-guided sacral plexus block, the prerequisite for this is you have an intravenous access, vital monitoring, then ultrasound machine with curvilinear probe and PNS machine with 10 centimeter needle. Drug you can use either 0.5% bupivacaine with lignocaine with dexamethasone, or you can use 0.75 ropivacaine 15 to 20 ml with dexamethasone, or 0.75 ropivacaine with lignocaine 10 ml 10 ml with dexamethasone, your choice. And you need, because since it is a deeper block, you need a IV sedation. You can use benzodiazepine and opioids, fentanyl. And since you are giving sedation, you need an oxygen source. And patient position is the same lateral decubitus position. So first, in ultrasound-guided block, we'll see the Taha's parasacral technique. What is that in this technique? In this technique, if you see patient is in lateral decubitus position, this is the cranial head and this is the foot end. This is the lateral part and this is the medial part. This is the gluteal cleft. So you have to go up to the uppermost part of the gluteal cleft, then go laterally 8 centimeter lateral to the gluteal cleft. At this point, when you put the curvilinear probe, most of the time you will see sciatic nerve. Sometimes because either obese or because of so much of muscle mass, you won't able to identify. Then you move your probe little cranially. When you move your probe little cranially, you will reach the ilium, ala of ilium. when your probe is at the ala of ilium, you will get this straight line, which is signifying the ala of ilium. And you will see the muscles like gluteus maximus and gluteus medius laterally. This is the lateral part, this is the medial part. So you will see gluteus medius and the maximus. Then again, you start coming down caudally. And when you come down caudally, this straight line made by the ala of spine, there is a break, which is caused by the greater sciatic notch. So when you see that break in that straight line at that level, if you tilt your probe little caudally, then you will see the sciatic nerve or sacral plexus coming out of the greater sciatic foramen. So at this level, you will see the gluteus maximus muscle and the piriformis muscle. Piriformis is easy to identify because it is much darker, almost like black color muscle lying under the gluteus maximus, which is more having striations and whitish in identification. And this most prominent bony part is the posterior border of ischium, which we have seen is there. This is the posterior border of ischium, which we are seeing here. This is the medial part. So at this part, you will see this greater sciatic foramen, the sacral plexus coming out of it. If you go further down, like if you scan it further distally, like earlier you have seen this ilium. Here you can see the nerve is lying deeper and medially. As you come down, you will see there is a break in that ala of ilium, and the sacral plexus is coming from medial and down to laterally, coming up superficial and laterally. And as you go further after this greater sciatic notch, if you scan further caudally, the sciatic nerve comes over the body of ischium. This is the posterior border of ischium, and you scan caudally, then this white line will appear. This is the body of ischium, and the sciatic nerve lies just above the body of ischium. As you go further caudally, the sciatic nerve get detached or get away from the posterior border from body of ischium, and the muscle in between is the superior gemmelli. That means you are going to reach into the gluteal region or the subgluteal region. So that is the gluteal region you have reached. You have crossed the parasacral area. If you are seeing the superior gemmelli muscles. So next is the Bernstein's parasacral parallel shift. What is this? In this also the same landmarks he has used, that is the greater trochanter and the posterior superior iliac spine. Then they mark a line from posterior superior iliac spine to greater trochanter and then a midpoint. And they keep the curvilinear probe on the medial half of that line. There are two halves. This is the lateral half and this is the medial half. So they put the probe on the medial half of this line and slide the probe from kipholet to caudal and medially. When you put the probe here, you will see again ala of ilium here, straight line, and which is covered by the gluteus maximus and gluteus minimus muscle. As you slide the probe caudal and medially, there is again a break in this ala. That means you have reached the greater sciatic notch. At that level, you will see the sacral plexus or sciatic nerve coming out of the greater sciatic notch. Here again, you will see the gluteus maximus and the piriformis. Because gluteus medius has gone laterally and minimus has gone down. So under the piriformis, again, you will see the sciatic notch or sciatic nerve or sacral plexus. In this Bernstein's parasacral parallel shift, we will see the sacral plexus sciatic nerve in the longitudinal direction. So roughly around 2 to 3 centimeters, you will see the nerve in the longitudinal. Whereas in the Tah's approach, you are seeing the cross-section area of the sacral plexus. Which here you will see it is in the longitudinal. It is coming out of the sciatic nerve because the probe, if you see, it is in the line of the sciatic nerve. Sciatic nerve is lying like this. Probe is going just parallel to the sciatic nerve. So these are the comparison of the probe position in both the approach, Tah's approach and the Bernstein's approach. Here you have kept the probe perpendicular to the skin and at the level of transverse position. Here you have kept the probe oblique in the medial half of the GT to posterior superior iliac spine. Let's see how we live demonstration how we perform this. So in this, if you see 8 centimeter lateral. So this is the posterior superior most part of the gluteal cleft. Then you take a 8 centimeter lateral and put a probe transverse position. Then you will see the posterior border of ischium. And this is a sciatic nerve already seen. You are seeing sciatic nerve already. If you are not seeing, then what you have to do, you have to move your probe proximally or kephalate. As you go move your probe kephalate, you will see a straight line. This straight line signifies the ala of ilium. Okay. At that level, now again start slowly down. As you see, there is a break in this line. You will recognize the sciatic nerve or sacral plexus coming out. And above the sacral plexus, you will see this black color structure that is the piriformis muscle. So when you come out above the skin, subcutaneous tissue, gluteus maximus, and the piriformis. And in the medial side, you will see the pulsation of the inferior gluteal vessels, which you have to keep in mind while giving block because chance of getting injured. And below this here deep, you will see the pudendal vessels also. They are pulsations of the pudendal vessels. So this is the Taha's approach of blocking. The needle will come from lateral to medial and you will go deposit the drug under the nerve here. As you deposit the drug here, either in plane or out, since it is a deeper block, you can come out of plane also and you can deposit the drug over the posterior border of ischium or in the just under the sciatic nerve. So that is either in plane or out of plane you can come. So next is the Winston needle is coming like this and you will see that drug will get deposited under the sciatic nerve. Next is the Benston's parallel shift, in which again the posterior superior iliac spine you will mark and the greater trochanter you will mark. Take a midpoint and keep your probe obliquely over that line, just parallel to this line, oblique to the hip, to the pelvis. Then you will again see the straight line, that is ala of ilium, right? Then you again coming down kephalate, caudal and medially. Again, you will see that, see how big, you can see the nerve. This is the full nerve over the body of ischium, or you can say posterior border of ischium. This you are seeing in the longitudinal direction, longitudinal section of the nerve. Then this again black structure is the piriformis muscle. This is the gluteus maximus. So skin, subcutaneous tissue, gluteus maximus, piriformis, sciatic, sacral plexus, sciatic nerve, and this is the posterior border of ischium you are seeing. Again, you will see the pulsation here, that is the inferior gluteal vessel under the piriformis and above medial to the sacral plexus. So you can come from here lateral to this. The third one more, which is these days recently has been done, that is the parasacral ischial plane block. They are just we are also start using that block. It is for mainly for analgesia purpose, not for the, in this what we are giving, we are coming from this, we are targeting this posterior border of ischium, not nerve. We are quite away from the nerve and the posterior border of ischium. Will come here and directly hit this nerve, this bony prominence, that is posterior border of ischium, and deposit the drug 20 to 25 ml. The drug will seep along the curvature under the nerve and block this nerve. So that is parasacral ischial plane block, mainly for analgesia purpose. So now we will see the parasacral plexus block using Taha's technique. So I kept the probe transversely and we start seeing that needle is there and we are reaching, and this is the contraction we are seeing. That is the hamstring contraction, and we are getting also the foot response, that is the plantar flexion also we are seeing. So both plantar flexion and hamstring muscles are seeing together. Now if you see here, similarly, the needle is coming there and we will get start contraction and then we'll deposit the drug just under the, this is our sciatic nerve, this is piriformis muscle, and this is the gluteus maximus. So this is a posterior border of ischium. We will come here and we will deposit the drug just under the sciatic nerve. Thank you. With this, I will end my session and I'm open for questions.
Thank you, Vipin, for that elaborate description. But for the benefit of people who are just started using ultrasound, of the several techniques that you described, which one would you choose and tell? Because that they have to master one technique.
So then I will go with the Taha's technique, sir.
Yeah. If you are going with Taha's technique, can you just describe Taha's technique alone once? Get back there and...
so if you see the Taha's technique...
With the ultrasound, pull the Taha's technique alone once.
Yes, sir. So in this Taha's technique, if you see, this is the patient is in a lateral decubitus position. This is the foot end and this is the head end. And this is the gluteal cleft. You will see that gluteal cleft, uppermost part of the gluteal cleft. Just go 8 centimeter lateral to this and put a probe here. Curvilinear, you will use curvilinear probe because it's a deeper. Then at that point, you will see most of the time sciatic nerve. If you're not able to visualize in this at this point, then you have to move your probe slightly kiphled. When you come probe move kiphled, you will reach the ilium, that is ilium. Then you will get the straight line, this straight line. Then again you start coming down caudally. When you come caudally, there is a break in this line. That is greater sciatic foramen is starting. And from there, if you see the nerve will start coming out of it, greater sciatic foramen. And from that, if you see the sacral plexus is coming out of it under the piriformis muscle. Here you can see both, and here you will see the medial side. You will see the...
So what you said. Yeah, Vipin, based on your clinical experience, majority of the times,
voices.
You just keep a probe 8 centimeter away from the uppermost part of the intergluteal cleft, and majority of the times you will be able to visualize the sciatic.
Yes, sir. And either this way, right? You can just have to tilt little caudal, sir. You have to tilt the probe little caudally. The nerve will get, because you have to go in the cut, you have to cut the nerve perpendicularly. So if you tilt the probe little caudally, the nerve will get bisected by the...
And do you recommend that if they... Okay, do you recommend that when they are using it for the first time, do you recommend that they can use a dual...
Yes, sir. I always prefer in the initial phase dual
and as well as a 100 millimeters stimulating needle.
Yes, sir. Most of the time it is, because it is a deeper, so 100 millimeters is appropriate for using it, sir. And with this, you can avoid the nerve injury also if you're using the nerve stimulator along with it. Because the deeper nerve, sometimes you won't able to identify properly because of so much muscle mass is there.
Message is very simple. When we use the parasacral approach, Taha's parasacral approach seems to be the easiest. And I think you have a question. For PFN, we have to add femoral block too. Yeah, that's true. That's all.
So you have to either...
I think...
So either you have to give femoral block or you can give suprainguinal fascia iliaca block or lumbar plexus block. If you are giving femoral block, then you have to supplement femoral block with the lateral femoral cutaneous nerve also, because the incision will be on the lateral part of the upper thigh.
Vipin, what are all the surgeries that we can perform with the help of parasacral
So with the parasacral
block
approach,
as an anesthetic block.
sir, alone we have to supplement either femoral nerve or saphenous nerve whenever you are giving a parasacral block. You can do all surgeries over the thigh or the posterior part of the thigh in the popliteal fossa, and below the knee, all surgeries we can do along with the parasacral approach with the supplementation of saphenous nerve.
Yeah. Good. Excellent. Arthur, do you have any questions?
Wow, Dr. Bala, you seem to have asked the questions I was thinking about asking. With that, I think I would ask our colleagues if they have any other questions other than the ones that you have asked. Any questions? Please feel free to ask questions. If not verbally, you can always type out something in the chat box. We can read your comments and respond to them appropriately.
Actually, this seems to be extremely helpful when we deal with critically ill patients who come for a diabetic foot with a diabetic ulcer, or sometimes even which has gone for a gangrene and hemodynamically unstable, and then you wanted to go for a below knee amputation. So substitute the 6 block with either a femoral or a saphenous, then you'll be able to get it done without any changes in the hemodynamics.
Yes, sir.
And that's a problem we continue to have here back home. We are having to do spinals since we're not very proficient with the sacral plexus blocks. And we have problems with, as you may expect, hemodynamic stability in these patients with some with, especially the patients with wet gangrene when they come in with diabetic complications. So I think this is a very important technique that we should all endeavor to learn.
Yeah, I will advise you to start using this. Even with peripheral nerve stimulator, you will get a very great response. And it's very easy to perform also, because it is not that like gluteal or subgluteal, it is much superficial. You will get all other nerves also will get blocked for doing hip surgeries, like superior gluteal nerve, inferior gluteal nerve, and posterior cutaneous branches of the femoral nerve. All will get blocked. So you can perform any surgery on the back of the thigh and below the knee joint.
Thank you very much, Dr. Vipin. Any other questions? I must commend you. I enjoyed this particular presentation. The anatomy and the explanation of it was very clear, and I like the incorporation of the peripheral nerve stimulator technique as well, because not all of our colleagues here have ultrasound, so I think it's relevant, especially for our setting. Thank you very much for that.
Arthur, I see Dr. Sonia here. Can we get a note from her about what she felt about it?
Dr. Sonia Creamy, is that?
Yes. Yeah. Maybe I think she is muted, but I see her there. Okay. Okay, that's fine. And Arthur, any other comments, opinions from any of your colleagues?
So far, no. But I'd just like to emphasize on the peripheral nerve stimulator technique. I think it's something we should consider for future presentation. that we should incorporate that as well. The PNS is very relevant in our setting. So our request is that there should be a segment just like it has been done today with the future presentations.
Okay, great. So I see one question coming up from Dr. Varshali Kenya. What to be done about obturator nerve, especially if tourniquet is required?
Sir, I didn't get the question.
No. We said, you said that most of the surgeries can be done. The question is, what about the obturator nerve? We spoke about femoral and the saphenous.
Sir. So most of the time,
and I think the question is to be used.
Question. So most of the time when we use they're asking about tourniquet, sir. I didn't get the question.
Yes.
So when we use thigh tourniquet, usually mainly the part we covered is the femoral nerve part and the posterior cutaneous nerve, which is supplied by the femoral nerve and the sciatic nerve. The very little medial most part is supplied by the obturator nerve. And if you are giving minimal of sedation, that will be covered. And first 45 minutes to 1 hour, that also patient won't feel initially.
Okay. So have you faced any complications with this parasacral plexus block? Is the question from Dr. Raghavendra.
Still now, sir, we have done almost 500 to 700 blocks. Till now, we have not faced any complication with this.
Excellent. So Vipin,
but you have to be very...
one more thing. What would be your suggestion that we discussed about patients in whom a neuraxial block cannot be given because they may have been on antiplatelets like clopidogrel. And considering this parasacral plexus block to be a bit more superficial, would this be a block which we can think of in critically ill patient who definitely needs a debridement?
Yes, 100%, sir. There is almost nil chance of getting any hemodynamical changes. And vessels is only inferior gluteal, that is also quite medially. If you keep your needle laterally and if you are using ultrasound, there is no chance of any hematoma or any injury to the vessels.
Okay, excellent. I think that we have answered all the questions. And thank you very much, Vipin, for the excellent depiction. And I think Dr. Arthur felt that the slides that you showed were very self-explanatory and very lucid. Thank you so much. And I hand over it to Dr. Arthur to close the meeting. Over to Dr. Arthur.
Thank you very much, colleagues. It's a continuous learning program, and we continue to benefit from it. I must apologize. I may have been mixed up. I was expecting to have a lumbar plexus block. But anyway, today's presentation was just as great. I extend an invitation to all our participants today to join us again in 2 weeks. We shall advertise again the topic of discussion for that particular day. And to today's presenter, thanks very much. We're very much stimulated by this presentation, and we're very grateful. Dr. Bala and the team at Ganga Hospital, we are ever so grateful, and we hope that we can continue to collaborate on many other collaborations other than our current ones. With that, colleagues, I'd like to thank you all and wish you a productive weekend. Thank you very much, and see you in 2 weeks' time. Thank you.
Okay, bye-bye. Thank you.
Thank you, sir.
Thank you.